Good morning, everyone. This is Larry Boris, Executive Director of the National Association of Worksite Health Centers. I want to welcome you to another of our programs to improve the value of worksite health centers and to respond to key and timely questions that relate to employers and others who have these centers or are supporting employers in doing so. I'm pleased to have today David Kite, who's the principal and leader of the National Worksite Consulting Service from Mercer, will be joining us today talking about a key issue that's impacting employers and has been impacting employers and other vendor partners ever since the beginning of the HSA law. As you all know, health savings accounts are prevalent among employers, and what we find is that under the IRS code and regulations, if an individual has a health savings account, an employer must charge some fee for worksite health center services, even if the employer doesn't charge any other individual in the workforce or the covered population. There's also a number of other provisions relating to worksite health centers that are impacted by HSAs, and under the new COVID-19 requirements and regulations as well. And so we have David joining us today who will be talking about that. And so David, let me turn it over to you.
Great. Thanks, Larry. Can you hear me?
Yep, can hear you. Just share your screen with everyone.
Great. Let me take over. You see it?
Yep.
Great. And thanks everyone for joining. Honestly, it's kind of nice to talk about something other than COVID these days. So just for a short while, so we had in partnership with Larry and the NAWHC back in Q4 of 2019 had gone down the path of conducting this survey. This is the second time that we had done it, and for our clients, we found that it was a valuable exercise in digging deep past kind of the high level issue around the IRS guidance and understanding kind of the underlying nuts and bolts and data that can inform our decision-making process. And because I think often kind of the question from our perspective starts with, what do we need to charge? And then as we start to kind of peel back the onion, we realize that there's many different underlying choices in how this is administered, which will lead to the best possible outcome and patient experience. And this is important because, as we verified in our biannual broader survey, that employers feel that having an HSA in coordination with their clinic, that the need to charge does influence utilization. So we know that this is a sensitive topic that can impact getting the engagement between the patients and the providers that we want. So hopefully this will be helpful information to share and welcome questions. So we conducted the survey in Q4 2019. It was released to employers that had both clinics and high deductible health plans with HSAs. 59 organizations responded across 10 different industry segments, the largest being manufacturing, but it's generally representative of what we see in the marketplace and kind of broad industry segments. So starting with kind of the concept of clinic management, and this is important because I think it does influence the decision-making process, having a partner at the table that can inform the choices that are made. I think probably important to call out is that often what we see as part of this process in deciding what to charge and how to charge, the how to charge is often heavily influenced by the vendor partner that you have and their operational infrastructure. But what to charge is often pushed back to the employer in making choices around what that fee is or the different tiers of fees that you might choose to implement. In focusing on clinic management, obviously we have a number of different organizations that are represented in partnership with their employers that responded. 83% of the respondents came from employers that were in outsourced management relationships, which is consistent with what we see approximately in the market. And the vendors presented in the list approximately align with the size of the vendor's book of business in the market. So I think it's consistent. How the HSA plan is offered, 74% offer the HSA alongside other plans. In that scenario, just under half charge HSA members more than members on the other plans. And this is important as we get into concepts of benefit parity, making the kind of underlying choices around how the HSA plan is presented to other plans is something to incorporate into the decision-making process. And looking at how we handle employees who have waived coverage is also something to think about. And in general, as we kind of go through the process of designing an administrative plan around how we deal with this issue, I think it's important to understand the different cohorts that have access to a health center and mapping out what services they have access to, and then leading to decisions from an administrative perspective. 34% of respondents said waived employees can't use the clinic. And if they do have access, most employers charge them the same amount. And for the situation of waived employees with external HSA coverage, another topic that comes up, 86% of employers don't take on the administrative responsibility of adjudicating a charge. And that's consistent with what we see anecdotally, that often kind of the administrative process that we see set up is that if a fee is collected, the responsibility of sharing that fee information with an external carrier is not taken on by the employer. They'll give it a receipt and essentially place the responsibility on the individual member to share that information back with their carrier. From a fee perspective, how fees are charged. So as we know, the IRS guidance is vague, so we see different approaches in this area. 48% choose to charge a single flat fee. And note that about 30% of employers are not charging for services, as we note at the bottom. In many cases, what we see in that type of a situation is that the employer is aware of the fees that or the regulations with IRS guidelines, and they essentially accept the risk. Often cases it's for specific locations where the population is extremely sensitive to the introduction of a charge, where maybe there hadn't been one before. And others may be kind of looking down the road and aware of the policy changes that we're hoping for in Washington, and hoping that they don't need to make a change, although at this point we're not optimistic that's going to happen anytime soon. So as we get into benchmarking, so as we go down that conversation around how do we determine what fee that we need to charge, essentially the framework is really a benchmarking exercise, and that begins with looking at what other available sources for benchmarks that we have. The most common is starting with the medical carrier allow fee schedule, and that is a realistic benchmark, just given that members have access as a decision point to a community-based primary care provider or urgent care provider as an option. They also then would supplement that kind of baseline benchmark with understanding what other employers that offer similar clinic scope of services, what they are choosing to charge. Many will look at that Medicare rates at 20%. Some who really get into the weeds, I think would look at their clinic unit costs and try to understand what the cost is directly per visit to deliver the service. And going down that path, some vendor partners will maybe willing to offer their opinion in terms of their cost per service, excluding preventive services from that mix, what they think the cost per unit is as another additional benchmark. I think the thing to keep in mind as you think through these different available pieces of information and making a choice is to underline it that the employer clinic is different from the community. It doesn't have the same billing and administrative infrastructure that's needed for a fee-for-service model. So as we think about comparing what the medical carrier allowed fee schedule is and looking at that compared to the clinic costs, it really is apples and oranges. And so as we put together a report on what the recommendation is for what fees should be charged, that needs to be emphasized and communicated because often stakeholders are involved that don't really understand the fundamentals of what an employer-sponsored clinic is. So getting into billing and administration. So again, you got to emphasize in the fact that the patient experience from beginning to end needs to be considered. So in many cases, employers are adopting an HSA or have adopted an HSA, and where they initially the clinic was not administering a charge. So how that fee is collected, as well as how it's communicated to the member, is critically important to making sure that it doesn't negatively influence the choice to come to the health center. Just physically having to take a card out of your pocket, or in some cases cash, that is a pain point. And we've seen employees say, well, if I have to spend $20, I'm just going to go to my provider in the community. I'm not going to come down here. So making this as seamless as possible is critically important. So from the data and using this to inform our decision-making process, what we can see is the vast majority use a point of service system for collecting payment. That's not necessarily a surprise in today's environment. Most avoid the collection services by using this point of service system. But I think it's something important to think about is that if you're not collecting point of service, or you're allowing members to walk out without paying for the service, then you'll need associated policies and procedures for situations where members don't pay, and having a policy for when a collection service might be implemented, if any. I think many employers choose to try to collect 2 or 3 times and then allow the debt to be waived to avoid employee conflicts. In this data, I think it is important and interesting to call out that 46% say they accept cash. It's actually surprising, and most, I think, would choose not to go down that path for associated risks and security of having cash on site or possible mismanagement. And actually, one last point on that previous slide is that I think it also thinking about the associated patient experience in having access to their billing records is an important piece. And so as you look to your vendor partner and their associated patient portals or mobile applications, the ability to see past charges or any charges due is important, as well as the ability to pay those bills via your mobile application is something else to consider. On this next slide, we know that the issue is that fee is a barrier to getting care. Most employers want to think about making funds available within the HSA account. Only 29% actually do make contributions into the HSA directly related to to clinic access. Often in a single lump payment, and then coordinated with proper communication, that the fees have been made available to further kind of try to avoid barriers to getting the care that is needed. So if they know that those funds are available, they may be more likely to come to the health center. We do see a few employers taking other paths in terms of considering how they can reimburse the member for those fees in a way that's compliant. And our attorneys have taken a look at it. And there is a way to do a payroll deduction and then reimbursement back into the HSA account as a more aggressive way to approach this. So I think, again, it kind of is based on the guiding principles that you want to eliminate barriers to getting the care that you need.
David, could you just comment, when an employer makes a contribution, is that done on an annual basis, or is it a contribution based on the expenses for the patient, the copays and the visits that the patient has? Does the worker notify the employer that they've had this, and then the employer submits it to the account, or is there some kind of lump sum that's submitted?
In my experience in the cases that we've seen this, it's been in advance, that essentially we look at the data and try to project what number of visits they would have in the course of a year. Typically, in the primary care area, it's, our Mercer national average is 2.6 primary care visits per year. So making funds available for 3 or 4 visits is kind of in that range of where we'd start to think about it. And potentially higher if the more generous the employer is. So that's typically the approach, that we make those funds available at the beginning of the year, and rather than on a per use basis.
Great, thank you.
So the last 2 slides was more about the more recent changes. So in this question, we asked about, have you had many changes in response to the 2019 IRS guidance that essentially expanded the set of preventive services that can be provided without jeopardizing a member's eligibility to make or receive HSA payments? And I think that the takeaway from this data is that only 29% had taken formal action. It's a little bit difficult to read through the data and the information that we responded back on exactly what operational changes may have taken place. Sometimes I think at the vendor level, changes may have taken place without the employer being aware of it, which is, I'm hoping, is the case. But I think maybe some were just unaware of the change, but it does expand what services can be provided without a charge, and then for that other category, we extracted some of the responses of that on what was going on with that specific employer set. For the most part, it's kind of consistent with the other 3 categories of the monitoring and potentially making a choice in the future, or not adopting anything.
And David, is Mercer making a recommendation to employers relating to this?
The recommendation is just to operationally to make sure that, as you think about, and often it's at the perspective of coding or administration, is that the clinic is appropriately applying the new regulations and working with the vendor partner to make sure that there's no situations where a member might be charged when they shouldn't have. Incrementally, I think the point of view is that while this is a positive step, it doesn't significantly change the issue itself. It only minorly helps by avoiding a small incremental level of service that might have required a charge in the past.
Thank you.
And then the last slide here is focusing on our data from our April survey. And asking about what actions have taken place based off of the recent IRS changes that relax the rules requiring fees for telemedicine services and associated HSA plans. This is important, just given that we have in this current environment, we do have increased flexibility. I think as we look at the information, which really just says that most have waived fees for COVID testing and treatment related services. And there are 11% that haven't made changes with that when they have associated with their HSA plan. I think the important thing to think here is we think about how long we might be in this environment with the pandemic, where it's looking like we're going to be in here for another 12, possibly 18 months or longer. We don't know how long these restrictions will be lifted, and we'll need to reevaluate things as we monitor and go forward. But it is important to recognize that there is an opportunity to relax our fee collection process. So that we can open it up for questions.
That's great. Thank you very much, David. We very much appreciate this timely, important information. Let me just start out with a couple questions that have come in. First one is, when we charge a patient for services at an employer clinic, do the collected fees get applied to the patient's deductible? And if so, how is that done?
They do, and that's an important administrative step that you would do with your vendor partner. So being able to submit fees, and it's typically done in a zero balance claim type file, where we're recording that we're not actually adjudicating the full value of the visit, but if we're charging $40, and as an example, we're sharing that record with the carrier on a regular basis, often weekly, sometimes monthly, or depending on the infrastructure, more frequently. But that is often either shared directly or through a clearinghouse, and making sure that counts towards the deductible. And that's another piece that should be highlighted, is that the regulations require that we charge for clinic fees up until the point that the member hits their deductible, but you're not required to charge after they've met their deductible. So only a small percentage of employers within the data said that they were charging after they met the deductible, but we encourage that you try evaluate the capability to stop charging at that point, given that it's a barrier to getting the care you need.
Okay, thank you. Next question was, for those not charging employees with an HSA to use the employer clinic, how long do you expect until the regulators enforce the need for someone to pay something? And also, this is a secondary, are you aware of the government going after any employer or vendor who is not charged fees for HSA people?
You broke up a little bit, and I think I captured the gist of the question. To our knowledge, there are no situations where there's been an audit or any employer or individual caught in a situation where the fee should have been applied for significant non-preventive services and was not. And so at this point in time, we can't point to a case study about how that would be handled. If you could repeat the beginning part of that question, make sure I got that right.
Yeah, the question was, do you expect that to change and the regulators to go after employers and vendors who don't charge fees?
Yeah, I don't anticipate that, and seems like the conversations that we're seeing from employers and kind of as well as what we're hearing informally in Washington is that the movement is actually in deregulating it and loosening restrictions. So I don't anticipate that this is going to swing the other way, and that there'll be any kind of proactive auditing or evaluation.
Okay, great. Thank you. All right, what I'm going to do now is to go around the table, excuse me, and just ask everyone if they have a comment or question. And if I miss you, just let me know. So I'm going to unmute everyone, and we're going to allow that to talk. So let me start out with Alex Jordan. Alex, you have any question or comments? Alex? No? Okay, let me ask Jeff Paddock. Jeff, you have any questions or comments?
Not at this time, Larry. Thank you.
Okay, thank you. Angela, do you have any questions or comments?
I do not at this time. Thank you.
Okay. Brian Lewis, you have any questions or comments?
I did, and it was already answered, so thank you.
Okay.
No additional.
Thank you. Corey Austin, any questions or comments?
I do not. Thanks for the information, gentlemen.
Okay. Stephanie Eckhold, any questions or comments? Okay, Jess Schaefer.
No questions from my end, but thank you very much.
Okay. Jeannie Rudy, Jeannie, any questions or comments? Okay. Julie Gilliam, any questions from you, Julie? Go ahead.
Sorry, this is Jeannie. I tried to unmute my microphone in time and it didn't work. This is great information, but the couple questions that were already asked answered the questions that I had. So do we think that the legislation is going to change? I mean, is it what's out there already pending that potentially could change charging patients that are on an HSA?
Larry, do you want to capture the kind of the recent update?
Sure.
I think you sent out a week or two ago.
Yeah, so the National Association of Worksite Health Centers has begun forming a collaborative to call the Fair Market Value Collaborative to try to find ways to modify or repeal this requirement that employers charge some fair market value fee for people with HSAs in the clinics. We are in the process of exploring our options. There's a number of organizations interested. If anyone on the call would like to learn more about this, let me know. But we do feel that there's an opportunity here with the government changing the requirement for COVID-19 testing and screening, that in fact that you don't have to collect the HSA's fees. And we think that this could be an opportunity in that there's a realization that Worksite centers some real access during this crisis, but on an ongoing basis. So keep looking at the NAWHC newsletter and on our website. We'll get more information. But if you'd like to participate or continue to get information about this, just send me a note. Be glad to do that. But right now, the requirement is just waived for COVID, the testing and treatment. There are some employers that are somewhat concerned that if they treat that condition that turns out not to be COVID-19 related, there could be some concern about that, but we don't know that that'll be the case further on. Going down the list again, Laura Bushman. Laura, any questions or comments? Okay. Matt Riemann. Matt, any questions or comments?
Good morning, gentlemen. Thanks, Larry. David, good to hear from you again. We work with certain employers who, in working with their counsel, have arrived at the conclusion that certain workplace clinic services, acute services, are by nature preventative and of de minimis value. Have you had any experience in working with employers that have justified not collecting for those types of situations?
Not in my direct experience, and I've anecdotally heard of some that have taken that approach. Our attorneys, while not providing formal legal counsel on the issue, are very conservative with the interpretation. So I would likely push back on any in-house counsel's opinion on that.
Yeah, I would tell you, I've come across a handful of employers who've told me that their legal counsel has told them that since they're only providing wellness and preventive services, that they don't have to worry about the HSA requirement. And, you know, they go by their legal counsel. We caution them. Well, we find in our own surveys that about 25% of our members are not charging for a variety of reasons. And whether they're aware of the situation and have accepted a risk, or just feel that it is a preventive care service and it should fall under the preventive care list of items and services, I guess that's an approach that you can take. But we're recommending from our organization that everyone charge some amount. And I would tell you from our surveys, we've seen companies charge as little as $10 and as much as the network provider fee. So there's a broad range.
Great, thank
Affordable
you.
Care Act was first developed. I was in Washington, and I found that there were people who wanted to define the regulation, but in fact, the IRS still does not define what that is. So there's plenty of flexibility at this time. Okay, a few more people listed on the call. Let me see. Tom Zawadzki. Tom, any questions or comments? No? Rebecca Reimer. Rebecca, any questions or comments?
I do have a question, and I'm sorry if I missed this. It was on slide 9, I believe, about the employer contributing to the employee's HSA. And David mentioned that sometimes that the employer would project what number of visits the employee would have and then add that at the one-time lump sum. Is that on an employee by employee basis, or is that kind of across the board considering everybody?
It's across the board
Okay.
at the eligible population level.
Okay, that's what I just wanted to clarify that. Thank you.
Sure. I do want to let everybody know we will have copies of a recording of this presentation, as well as the slides, which will be available on the Now website. But we will be sending copies to everyone who registered for the program here, as well as an evaluation form. So we'd ask that you try to complete that. Michael Piercefield, any questions from you, Michael? Yeah. Okay, anybody else in the participants who'd like to ask anything?
Yeah, I have one question.
Go ahead.
I haven't been charging in our clinics, and we have a new potential clinic that has brought these HSA issues to our attention. And I had the question about how do you apply it to the deductible. Now, I have clinics that use regular insurance, so I understand how to use clearinghouses, but what kind of code do you put in? Is it just a general code that $40 was charged for service, or is it regular CPT codes used? How do you go about submitting it to an insurance company?
I'd defer some of those specifics to our operations team, but we can follow up and get you an answer on that. And I don't know if Larry, you have something off the top of your head.
No, I don't. If you want to send it to me, David, I'll make sure that Christopher receives a copy of that.
Great.
All right, well, with that, I want to thank David Kite from Mercer and for his participation. Thank everyone who was on the call today. We're looking forward to having you participate in our future programs, but keep an eye out for the upcoming events, both on our website. Also check the NAWHC LinkedIn group. And for those who are not members, please visit our website, and I'll be glad to provide information on what's going on. Thank you all, and stay safe and have an enjoyable week. Take care, everyone. Bye-bye.